have questions, we're recording.
There we go.
If you have some questions as you go along, I know you can put that in your chat, and they're kind of monitoring that. I don't think I can see that, but we will get to that. So hopefully it can be kind of as interactive as it can be. I'm going to kind of go back and forth between sharing my screen and kind of chit-chatting. If I end up losing you, you'll know where I went. I'm lost behind the screen. So, you know, so this is a topic I think is super important and pertinent to all of us for the most part. I mean, we all know someone who's had a serious illness, or you know, in the past, in the present, or we will at some point in time. And so the goal of this that I have is just to kind of give you some general information along the course of this illness. And so we're going to start kind of at the beginning with it's, you know, the idea of this is kind of the club that, you know, nobody really wants to belong to, you know, the diagnosis. And, you know, when we first think about diagnosis and treatment, we really think of it in very medical terms, don't we? We're thinking about going to the doctor and tests and blood work and so on and so forth. But, you know, one of the things I want us to think about is that I always encourage people to be active participants with their care team. So it's not just about, you know, you're this passive recipient of medical care, but you want to choose your care team wisely. So sometimes what happens is folks get, you know, have a symptom and they just kind of end up in the emergency room or maybe with their primary care doctor, and they just kind of get funneled into that system's network of specialists and testing and so on and so forth, which can be completely fine. Other times there may be better care options. So for example, you know, we're fortunate in Kansas City that we have many hospital systems to choose from. And some specialize in certain illnesses and may be more on the cutting edge of things than other hospitals. So think about that as you're kind of getting into this. You don't, just because you start one place doesn't mean you have to stay there. Kind of along with that, I always encourage folks to choose your information sources wisely. So when we think about that, Google is our friend and our foe, right? I mean, we can find a treasure trove of information. Some of it is fantastic and super helpful. Some of it is maybe a little out there or not exactly accurate. So that's something that we want to make sure to, you know, just be cautious about, think about, and be mindful that what you're doing actually makes sense. And you know, most of the time, physicians or your healthcare providers can kind of help guide you to some resources on the internet. You know, your neighbor who had this illness 5, 6, 10 years ago probably is not necessarily your best source of information because medicine changes really quickly. So just be wise, think about that. The other tip I have is that when you're in this medical setting, you're going to these appointments and so on, write your questions down ahead of time and then jot down their answers. I think it's always surprising for myself personally how much I don't remember until I look back at my notes that I've taken. It really does make a difference. So obviously what, you know, happens between, you know, after a diagnosis and you're kind of going in the care team, that is, it affects lots of things. It affects more than just your physical body. It affects every aspect of your life. And that's really, you know, what we want to hone in on are some kind of practical tips and ideas on how do you navigate that, because it affects every bit of your life, your social life, your financial life, your emotional life, your relationships, your work, so on and so forth. So one of the things, is my screen flipping back and forth? I can't tell. Is it? Am I flipping? Yay, I'm glad. Okay. I'm more successful than I thought. So when we think about the practical and sometimes financial aspects, I want to encourage you all to really think about advanced planning, and that can mean a lot of different things. I know that they sponsored a great session on doing some of that financial or some of those early conversations about planning for your care, but I want to hit on just a few pieces of that. So one piece of advanced planning is a living will. And it's also called an advanced directive. And what it does is it really is kind of tends to form, it's most typically it'll say, do you want, in the event that I have a terminal illness and, one or two physicians don't expect that I will make a full recovery or significant recovery, you say you do or you do not want certain treatment. So I do want chemo, I do not want chemo. I do want surgery, I do not want surgery. It could be dialysis, it could be tube feedings. I mean, it could be lots and lots of different things. And I think one of the problems with the advanced directives that are worded like that, and most of them are, is that we get really hung up on those treatments. So, because that's what it's focused on. Do you want this treatment or not? Check it here if you want it, initial over here if you don't want it. And that's okay, that's important. I mean, it's not something that we don't want to have, but I want us to consider more about how do we want to live versus what treatments we do or don't want. Okay, so consider how you want to live instead of just what do you want these treatments, yes or no. And the reason for that is because what might be an appropriate treatment for me today might help me get back to a quality of life that I want, might not help me be a good tool for me down the road 10 years from now, 1 year from now, depending on what's going on with me. So for example, if I, were, if something happened, of course I would want surgery right now. Yeah, try to fix whatever's going wrong. But for me, if I'm a 90-year-old woman living in a long-term care center with dementia and many other health problems, who's bedridden and just really can't do much, I probably am not going to want a really major invasive surgery if it's not going to really improve my quality of life. So that's what I mean, is that think about how you want to live versus what treatments you want. It's not necessarily about this, it's not a menu of I want this one and that one. It's really more a written directive and a conversation with your important people about how it is you want to live. One of the things, when I talk to folks in my experience in a hospital, I would ask them is, people that didn't have this advanced directive, I would say, was your dad the kind of guy that, did he ever talk to you about what he wanted? How did he want his life to end? Would he want to be on a machine? Would he not want to be on a machine? And I can tell you that the folks who had this in writing, those family members were able to cope much, much easier because it was that person making the decision for themselves as opposed to the family member. So that's one piece of advanced planning. Sometimes it's all glommed into one document, but sometimes it's separate. Another aspect is power of attorney. And there's two different kinds. Again, sometimes they're glommed into one, depending on how it's written and how it reads. But a power of attorney could be financial or it could be medical. And the important thing to know is that the power of attorney doesn't necessarily take effect immediately. So by creating a power of attorney, it's not saying that, oh, I'm letting so-and-so make all decisions for me from here on, no matter what. Maybe it says that, But typically it has to do with if you're not able to make those decisions yourself. And so that power of attorney starts typically when you can't make those decisions, and it ends either when you are able to make decisions, you're conscious or you're not confused, or at death. Okay? Super important. In Missouri, what we have is we do have next of kin where we can go to the next of kin to make those decisions if there's not a power of attorney, but it really helps a lot if we can, you know, have that all written out and tightened up. Okay, so another piece that is actually not a piece of advanced planning, but people think it is a do not resuscitate order. Do not resuscitate. If you go into, any of us go into an emergency room for anything, you cut your thumb real badly and need stitches, they probably are going to ask you, are you a DNR? Do you want to be resuscitated? And, you know, for most of us, it's kind of like, oh yeah, it's a no-brainer. Or for some people, they think it's saying that it's foregoing all treatment options. Basically, a do not resuscitate order is a doctor's order. The doctor has to say, this is what they want, I agree, blah, blah, blah. And it's simply saying that if your heart stops, your breathing stops, they're not going to try to get that going again. And that sounds like kind of crazy, like, well, that should just be, why wouldn't we want that, right? Breathing and heartbeats are good. So this is something that I always encourage folks to get educated about because it's not that simple. What we know is that sometimes it's more of a burden or can cause more problems than it helps, especially with people who have a very serious, significant illness. So in the normal, general, healthy population of people who are in a hospital setting and their heart stops, their breathing stops, and they have resuscitation like CPR, the studies are a little bit different. 20 to 30% of those people survive. That's a pretty low percentage, isn't it? We're not talking about, you know, we're talking about the general population. That includes, you know, people that have no other major known medical history all the way to the 101-year-old that didn't have a do not resuscitate order. So 20%, that's not a lot. And then it actually shrinks when you start including, you know, you start looking at age, you start looking at elderly people that are very frail, or with people that might be younger that have a really serious advanced disease like cancer or heart failure, things like that. Those percentages go down much farther, down to 1%, 5% survive, okay? So for some people, they think, okay, well, 1% chance is better than no chance, okay? And that might be a very fair, you know, assessment, and that's what they really truly want. But instead of going to, again, consider how you want to live versus what treatment you want, because out of that 1% to 20 to 30% that survive, very few of those people will ever return to the condition they were prior to the resuscitation. So many of those people are not going to be able to get off a respirator, a ventilator. Many of those people are not going to be able to get out of bed again. Many of those people are going to suffer cognitive impairments because of the lack of oxygen. And so it really becomes more of a gray area, doesn't it? When it's not so yes or no, I want this or I don't want this. And that's where I really encourage folks to dig a little bit deeper, ask their physician to talk with them about that in their own specific circumstances. If you have a DNR, you still can get every other treatment in the world. It just means that if your heart and your breathing stop, we keep you comfortable and we allow that to happen. one of the doctors I work with, he said for our people that are very, very ill and on hospice, it totally makes sense for them to have a do not resuscitate, because it's not fair to die twice. Nobody wants to do that twice. We know that resuscitating is not going to change their story. So that's kind of sobering in some ways, but it's also, I think, a little bit freeing when you're in that position. The people that I've talked to, especially older people, they're pretty clear. They're like, when it's my time is here. I'm good with that. I don't want to undergo that. It can be a very physically brutal process. I mean, they have to physically manipulate your heart. I mean, it's not like on TV where they go, zap, and you're done. So anyway, so think about that. Talk to your physician. That's important.
Katie, we do have a quick question. Yeah, we have a quick question. This takes it a little bit back to the question of choosing specialists or choosing your care team. How does the process work with, or would you consider, or what do you know about how insurance, maybe the insurance coverage that someone might have, be a greater determinant in their
yeah, that's
care?
Yeah, that's a great question. And yeah, so you'll want to check into what providers are covered or in network, and if that even comes into play. You know, for folks that have Medicare, right now we're in open enrollment time. And so if you maybe are not real happy with your insurance, or for work too, this is kind of the time of year where we can make those changes. It's absolutely something to look into.
Great, thanks, Katie.
All right, let's see where I'm at here. Okay, so under practical financial, we talked a little bit about kind of nuts and bolts of, paperwork and, the financial planning as far as, financial power of attorney. Here's another really basic practical tip, and that is just when you're diagnosed or you're undergoing a lot of treatments, get yourself a binder or a folder. It doesn't have to be pretty like this one, but put your paperwork in here. Once you have that power of attorney and you have those advanced directives, maybe you even have a paper that is out of hospital DNR, get those in that book so you can whip them out when it's needed. Also, other things, keep a list of your medications, keep a list of your doctors and their contact information. This sounds kind of silly, but even a medical history summary. So like, what have you been diagnosed with in the past? When have you had surgeries? When have you had hospitalizations? When have you had allergies? It sounds like, that should be a no-brainer, but I promise you, if you're not feeling good and you're in the emergency room, it's a lot nicer to be able to hand that and say, here's the information. Or, for myself, when my grandfather was in the hospital, I figured out real quick, or he was kind of going back and forth. I figured out real quick that I needed to get this written down because we were being asked about it often, and sometimes he couldn't remember, and sometimes the list of medicines was really long, and so simple, not a big deal, but I promise you it is well worth the time. All right. Oops. Are you on there again? Can you see my screen?
Not yet.
I was doing so good too. Hold on. We're almost there. I was doing so good. Doggone it. Okay.
You're doing great.
So, okay. Social emotional. Okay, this is like a huge topic all by itself. We could talk about this all evening and tomorrow evening and the next evening. I mean, it's a big, big topic, but we want to identify who's going to be your care partner. Like who is that? Who do you want that to be? So sometimes it might be your spouse or your daughter or your mom or your best friend. I mean, but sometimes it's not always the person that is maybe next of kin. So for example, when my mom, wasn't anything horribly, but it was her hip replacement, she had me at those appointments because my dad, he was just kind of lost, and he's a very capable, smart person, but his brain doesn't work like that, you know? And so, you know, I would be kind of the main care partner and keep track of the notebook and make a list of all the questions and the answers and just kind of help them go through that. So think about who that is for you. It may or may not be your spouse or your partner, you know? I also encourage folks to kind of hit things up front when you're telling your story or you're disclosing your diagnosis. Sometimes it's really helpful to say, you know what, here's my diagnosis. A lot of times the email works good, those caring bridges work good. Might be, you know, I wanted to let you know I'm been diagnosed with breast cancer, and I'm getting ready to undergo some treatment. And I want you to know because I think, you know, you're an important person in my life, and we're connected in this way or that way. But I also want to ask you to please try not to give a lot of advice. You know, a lot of folks are very well-meaning, but if you just set that up from the beginning to say, welcome questions, welcome encouragement, I'm not quite so interested in getting lots of advice right now, that can save a lot of headache, because people want to be helpful, but sometimes they don't know how to help. Sometimes I also encourage folks to, you know, disclose a new diagnosis or a new treatment and just say, you know, I wanted you to know, but quite frankly, I don't really want to talk about it a lot yet, but I still want to see you. I still want to get together and crochet or quilt or golf or whatever, you know, kind of set the tone and the expectation for what it is that you want.
Yeah, I really like that, Katie. And one other thing that I thought of as you were talking was maybe even just specifically asking for how you might want help. So maybe if people want to help you, right, but they just don't know in what ways that would be help, or, you know, what kind of help you might need. If you say, you know, you could always kind of outline a little bit specifically. I think that as someone who would, you know, personally, if someone asked me, I would be more than happy or really excited to help in that way. So, you know, having that clear kind of, this is how you can help is, I think, really, really nice. So
yeah, I agree. Yeah.
And we have one other question from the chat real quick. This also goes back to the your wonderful, helpful list of information to gather. Would a list of medications with maybe dosage information and the correct kind of amount and the exact names of the drugs be something that your pharmacy could print out or send you, or somehow kind of communicate to help kind of consolidate, make sure everything's accurate?
Yeah, if you're getting all your medicine from the same pharmacy, they should. Sometimes we pick up a medicine here and a medicine there, depending on where we're at. The bigger health systems, so like a KU, a St. Luke's, maybe an HCA, I imagine they're kind of connected. They're going to be able, if you're seeing multiple specialists or physicians within that group, it's all going to be in front of them too. And at some point you can ask your primary care doctor, say, hey, can you just shoot me a list? I need to get that down.
Yeah, great.
Yeah.
Thank you.
Yeah. Yeah, it changes. So it can be a lot. All right, let's see. All right, we identified our care partners. Okay, so let's talk rehab. So, you know, in spite of our best efforts, or maybe, you know, as a result of our best efforts, sometimes we get down a little bit, and we've got to get to a point where we regain strength, we regain balance, we regain some function, and we need some rehab. So let's see, I'm going to put these up. So I started, how do I want to do this? It's going to click through it. I think I'm going to put them all up, and then we'll talk about them. I'm going to click, click, click. Hang on. Okay. Whoops. Try it again. Okay. So from the left to the right, these are the least intense types of therapy to the more intense types of therapy. Okay. Oh, you know what I didn't put on there? I did not put outpatient therapy. So another one is outpatient therapy, where you just tootle on up to the clinic that is there, and you do your therapy and then go home. A lot of people use that. But I'm thinking more for folks that are pretty sick, are not as able to get out and around or need a higher level of therapy than that. So the kind of least intense type of therapy that's very common after folks have had a hospitalization is home health. Home health is meant for rehab. Your doctor has to order it. It's covered by your Medicare, your insurance. It provides nursing, physical therapy, occupational speech therapy and aid, wound care. It provides several different services like that come into your home, and with the goal to help you regain function, whatever that looks like. It is something that is intermittent, meaning that typically a nurse might come in once a week. Usually you're getting this once, maybe twice a week on each discipline, depending on what you need, maybe an hour or so at a time, and then they go and you're there to do exercises in between. An important thing to note is that Medicaid does not cover this. So Medicaid is for folks that are not old enough for Medicare. They don't necessarily have a disability that qualifies them for Medicare, but they have a financial need. Okay, so Medicaid does not cover this kind of rehab. The next kind of therapy that is a little bit more intensive is rehab in a facility. And that's usually like a wing in a nursing home. So facility rehab. This is also covered by insurance and Medicare. It also has to be ordered by a physician. Different insurances have different qualifications for that. So most of the time this happens after you've been hospitalized for a while and you just are not able to get home yet. You're just not strong enough or able enough to just get home and go back to your prior living arrangement. So here's the big thing with that is that for it's called skilled nursing rehab usually, or that facility rehab, you have to not only qualify for it, but you have to be participating, you have to be doing the therapy, and you have to be making progress towards your goal. So unfortunately, sometimes people, especially older people, sometimes will be like, okay, yeah, I'll go to rehab. I want to go to the rehab. But they don't want to go to rehab for therapy. They want to go to rehab to have somebody take care of them. And that's not rehab what it's for. You have to be participating and you have to be making progress. So that's a biggie. It's time limited. It doesn't just go on and on forever because it is meant to have an endpoint. Okay. Let's see. Our last one is the highest kind of form of therapy. It's called an acute rehab. They're actually getting 3 or more hours of therapy a day. So a lot of younger people, or especially stroke victims, will oftentimes participate in acute rehab because it's very intense therapy. It's a hospital-like setting, and it's actually covered like a hospitalization. So that can be a great option for some folks, depending on what is needed. This actually is covered by Medicaid because it is considered a hospitalization. So sometimes people they may start out as a acute rehab, not need quite so much, and either go home with home health. Sometimes they might be in a facility rehab and go home with home health. It can look different ways.
Okay, quick question for you here.
Yeah.
Are there considerations that are put into place when those kinds of, if you go back to your slide where you had the different levels of rehab, do those get kind of considered based on your living situation? So if you have maybe stairs that you have to climb to get into your apartment or to your home and it's not accessible necessarily, are there certain, and like maybe you can't modify, there's no way to modify that. Are there options for how kind of your rehabilitation to meet that need?
Yeah, and it really is. I mean, that could be one of the goals of therapy, is that I've got to get up 5 steps to get into my house. You know, that can absolutely be a goal of therapy. Hopefully that goal is met. Sometimes it can't be met. That's the reality.
Right.
And in those cases, that's when therapy stops, but then their job is also to work with you to figure out, okay, now what's next? So they're not just booting you to the curb. They're trying to help figure out alternative accommodations, as far as, you know, maybe it's a ramp, maybe it's a lift, or, you know, maybe it's more serious than that. But for sure, yeah, that's something that's addressed.
Great, thank you.
So, all right, so some folks, I'm glad you said that. That's a great question, because it's a good segue into what happens if you just don't bounce back up to where you were before. Okay, especially with older people, or with a serious illness that, in spite of all the best treatment, progresses to the point where maybe you're not able to walk safely without having some falls. Maybe you're not able to take your medicine on your own. You don't remember to take your medicine. Maybe it's that you do pretty well most of the time, but you get some spells where you just can't breathe and you need somebody there to help you with something. In more extreme cases, some people are bedbound. They can't even get up to go to the bathroom, or to get a drink of water, or to, you know, call for help if they need help. So in those cases, what do we do? So we're going to talk a little bit about caregiving needs. And so when I'm talking about caregiving needs, I'm talking about not skilled, not rehab. It doesn't necessarily require, you know, it's just kind of like, think of it like your room and board. It's what you need just to live throughout the day. What kind of help do you need to get through your day? So, all right. So some folks, non-skilled. So it can be in home, you know, sometimes people have caregivers that can come in. It might be family. That's fantastic if you have that. So oftentimes family is just not able to give the level of care, or maybe the amount of care each day that's needed. And so it could be private paid caregivers. For folks that are on Medicaid, sometimes they will qualify for some hours of help per day, for an aide or somebody to come into their home to help them. So you notice what's not on the list? This is the bad news. This is not Medicare and insurance. This is not that. Medicare does not pay for what they call custodial care, or just kind of basic caregiving that you need just to get through the day. They'll pay for therapy, they'll pay for nursing, but they're not going to pay for this just kind of daily sorts of care. So you can imagine this gets expensive in a hurry to stay at home. The going rate around here for agency, private duty agency care is roughly $20, $25 an hour and up. And it's actually, you know, quite cost prohibitive for most people. So that's one thing to look at. It could be that, you know, if you're a person that's going to need 24-hour care and you're not very wealthy, like the majority of us, to afford, you know, $20, $25 an hour just to stay at home, it may be a facility. And so it could be an assisted living facility, or it could be long-term care. And so obviously there's different levels of care with each of these. Some people, you know what, here's the thing too, is that some people, they would prefer to go live at a facility than to have their family take care of them. You know, they would rather keep their independence in that way. You know, I just worked this week with a lady who, you know, her closest relative was her son, and she wasn't able to get to the bathroom, and she's like, I don't want my son to help me go to the bathroom and change my pants. I mean, that's a reality. And so facilities are not always the last resort. Sometimes it's the first choice. Assisted livings, you don't need, it's for folks that are a little more mobile, don't need so much help. The kind of bummer thing with that is they're always out of pocket. Okay, Medicare or Medicaid do not pay for that. So and sometimes people are just not well enough that they can go to assisted living. Somebody that's bedbound or requires a lot of help to get up in the morning and into a wheelchair, those kinds of things, it would be a long-term care facility, which is what we'd think of as a nursing home. Okay. Again, nursing home is not paid for by Medicare. It's paid for out of pocket. And then after you meet certain criteria, that's way too complicated for us to talk about tonight. You spend down your resources, then Medicaid through the state will kick in and pay for you to be there. That's kind of, just think of that as like your room and board. All right, so payer sources, I already got ahead of myself. Yeah, so, oh, I'm glad I put that on there though. Long-term care insurance. Some people, especially older people, will have long-term care insurance, like nursing home insurance. And what it does is it usually has a benefit for in-home care as well as facility care. You know, so if you're older and you have that, that's awesome. Or if you are taking care of someone that's older, ask them if they have that. This is going to kind of, I think, be a thing of the past because the premiums are so incredibly high to start now, which is kind of a sad thing. It's I'm seeing fewer and fewer of these policies. All right, so let's think. So okay, so that was like a little whirlwind. A lot of information to take in, thinking about what might I need along the way. What does rehab look like if I just can't take care of myself at home? What does that look like? There's other treatment options besides being on, you know, focusing on a cure. And so let's talk a little bit about what that might look like. You know, with a progressive disease, chances are you're going to end up being here if you have that kind of a serious illness that does progress. So let me share my screen again. All right. So there's a couple of different things I wanted to talk about. One is palliative care and the other is hospice. And this is like really confusing because unfortunately sometimes these two are used interchangeably. Sometimes people will be talking about hospice because they call it palliative care. Unfortunately, I think that the word hospice scares a lot of people. Back in the day, you know, old-timey hospice, you know, people probably think of it as, well, I know a lot of people think of it as, you know, you just kind of are in a bed in a dark room and given morphine until you die. And that's really not what hospice is. But because it has such that connotation with it, a lot of physicians and nurses and other folks will call it palliative care. But there is a difference. Medicare pays it differently. There's actually two different kinds of programs that I wanted to explain the difference with. So palliative care is something that can be used at any point in a serious illness from the time you're diagnosed until the end of life. And it's a specialty branch of medicine that focuses on symptom management. So somebody, let's say that somebody has cancer and they're undergoing chemo, they may have a palliative care specialist that is going to help manage their nausea or help manage some of the other side effects of the treatment or side effects of the disease process itself. Sometimes people go to an office to see their palliative care physician. Sometimes it comes into the home. You know, it could be a combination of things. A lot of hospitals will have a palliative care team. And, you know, if I were to be diagnosed with a serious illness, I would start them early because they're able to help look at the whole picture, not just your lungs or not just your heart or not just cancer, but they're looking at how do all of these things fit together because our bodies are so complex. Maybe we have heart failure, that's going to affect our kidneys, isn't it? Because we're doing Lasix and we're trying to get the water weight off. And so now we've got more than one system going. And then you get more specialists involved, and pretty soon you really need somebody to help you see the whole picture, not just the whole picture of your medical condition, but also the whole picture of, again, how do you want to live? What's important? And helping you make those decisions throughout your treatment process. Okay, so palliative care, again, focused on symptom management, can be used all the way through the process. Hospice is palliative care, but it's only palliative care in the sense that it's only comfort. It's only to try to alleviate symptoms. So sometimes with hospice, we are doing a lot of the same kinds of things that someone who's not on hospice is doing. So for example, folks with end-stage heart failure oftentimes need Lasix to get the water, the fluid off of them, the edema out. So that's something that we do. We still do that. We don't just pull people off their medicines and say, we're just gonna, keep you doped up until you die. We're managing those symptoms. And the truth of it is that in an end-stage disease process, it's really kind of a lot of times that can be done anyways to manage the symptoms. There's a point in these serious diseases that, okay, we're not gonna cure it. There comes a point where it's not gonna be cured, it's not gonna be fixed. We're not gonna turn the clock back and rehab. What we're doing is managing the symptoms, and that's where hospice can really excel and shine. You have to qualify for it. You have to be, it's covered by Medicare, it's covered by insurance, and the vast majority of hospices will even help people that have no payer source. So hospice is a service, it's not a place. That is a biggie that a lot of people don't understand. So hospice is, we often hear about hospice houses, and there are hospice houses. What most people don't understand is that you have to qualify to get into a hospice house. It's meant to be 5 days or less stay typically, and it can go up from there if you still qualify. But it's really for people that are having crazy out of control symptoms that can't be managed elsewhere, or sometimes people that are just imminently going to die, and then they go to a hospice house. So the vast majority of people on hospice that use hospice services never in a hospice house. They wouldn't even qualify to be there. So hospice is more than a place. So it's a combination of just a different way to approach your medical care, to focus on that symptom management, to focus on comfort, combined with us looking at all of your life. What can we do to help your family or your friends? What can we do to help those that are closest to you cope, be caregivers? What can we do to help you have the very best day you can today? And if you can be active and feel good today and get out and go fish or whatever it is that you like to do, we want you to do that. But then we're also going to be there on the days that you don't feel good, and you can't do much. So it's hospice combined with one of those forms of caregiving, whether that's family or a facility or private people coming in. Hospice doesn't just stay there all the time, but it's a team, that's physician, nurse, social worker like myself, chaplain, volunteers that are just all focused on getting a plan together to take care of the patient wherever they're at. We don't do anything to make you pass away sooner. We don't do that. We also don't do things that are with the purpose of making someone live longer. The interesting thing is that studies have shown that people with specific diseases that enter hospice care oftentimes live longer than those with the same illness who do not, because some of those treatments take it out of you. And it just actually, just the very fact of simplifying what's happening, you know, keeping the medicines that help you feel good today and getting rid of the ones that are trying to prevent something down the road. Having that team approach that's looking at you as a whole person, not just your physical body, can really make a big difference. It really, truly can. Sometimes people come on hospice and actually do better for a while. But our goal is quality of life. And aside from the team, we do medication related to the illness. We have equipment, so hospital beds and walkers and bedside commodes or over the toilet kind of railing, oxygen, incontinence supplies, wound care supplies. Those are all things that are provided with hospice. And so a lot of people don't know that. And I think that's kind of an important thing. So that was a lot of information, wasn't it? Everybody's head spinning. We have questions.
Feel free to put any questions that you have in the chat or the Q&A, and we would be happy to answer those. But yes, that was a very comprehensive overview of all of the different
options. It was the trajectory, wasn't it? Yes. It was from here to here for sure.
Let's see if anybody has any questions here. I don't see anything coming through. Folks might be typing, so we might give a second, but we will be sending this recording out to you as well tomorrow with an evaluation, so you can let us know how you did, or how we did, not how you did, how we did, and so we can take your feedback and incorporate it into future presentations. I will put my colleague Jenny Starr on the spot here for a second. I know earlier we mentioned finding sources of information about healthcare decisions. So I might ask her to speak a little bit about her role at the library and what she does there.
Sure. So I'm the health and wellness specialist for the Kansas City Public Library, and I can help you to find reliable health information. One thing that we have right now is the Caring Conversations booklet, which I will be mailing out to those who would like to have it. I have several people that have asked for it, and so, as I'm working from home, I just haven't made it downtown to get them mailed out, but I will very soon. And then the other document that I have seen used in a different setting was called 5 Wishes. And Katie, maybe you know of other documents that I don't know about, but both of those kind of take you through different decisions you might want to make. How do you want to live? What kind of care might you want or not want?
Mm-hmm. That 5 Wishes was especially good for people in early stages or before they even have a disease. For older people or people that have a real advanced disease is too much, I find. At that point, it's really too comprehensive. But, you know, I think it would be fantastic, you know, for someone my age or even younger or whatever to fill that out, think it through. And I'm going to mess up their name. I'm Googling it now. It is the Center for Practical Bioethics.
Yes, that's the Caring Conversations booklet that we have.
Perfect.
Yes.
Get online, and you know what? They have power of attorneys and advanced directives on there that you can just download for free, both for Kansas and Missouri. And they're a fantastic resource. Your physician is going to have your power of attorney or advanced directive. Oh gosh, that's the other thing. If you have your advanced directive, whatever you do not put it in the safety deposit box.
Yes.
Because when you need it, no one will get to it. So I always tell people, make copies, give it to whoever's going to serve as your power of attorney. Make sure to take a copy into your physician. Make sure it's in your medical record. And honestly, I keep mine in the glove box of my car. I figure, well, somebody will be able to get to it. I'll say, look in the glove box.
That's a good idea. I'm just putting the link to 5 Wishes in there because we asked about it. We'll make sure that those links are in the email too. For Caring Conversations, you can go to the website and we'll send you that link, and you can download it electronically, but the library, we purchased 100 copies of it as well. So if you would rather have a hard copy, you can just let us know when you get it. Oh, look at your
Sorry, hi,
I love it. You can just respond to the email that you get and let us know your address and how many copies you would like. And you'll need, for the Caring Conversations booklet, you need one for each member of your household that wants to fill it out. So we'll get that in the mail.
Great. All right. Well, I thank you all so much for your participation and wonderful questions and engagement tonight. Thank you, Katie, so much for your valuable information and insights to the process and what resources and options are available for folks who are either experiencing this themselves or caring for someone, a friend or a family member. So we have one more session in our series left, so stay tuned for that next week. And I hope everyone stays safe, stays well, and be looking for our email with the follow-up, and you can find additional information. If you have additional questions or anything, just feel free to reach out to me, and I'm happy to connect you to whatever resources and information we can help with. With that, I am going to sign off, and I hope you all have a great rest of your evening, and take care, everyone.
Thank you. Good night.
Thanks, everyone. Thanks for joining us. Thanks, Katie.
You bet.